Then. I'd like to welcome everybody to this talk, and I'm sorry that we had to bail out of doing it face to face, but several of us were ailing and weren't sure whether we were going to be fit enough to actually turn up. So we decided we'd revert to doing it as a remote lecture. I'd just like to share my screen briefly to tell you about two events. The first is next month's event, which is a visit and a talk. It's at Labman Automation, who make robots and all sorts of gizmos and gadgets at Seamer Hill, Seamer, Stokesley. It is reasonably easy to find. It's the road from Seamer towards Stokesley that comes out at somewhere farm, I've forgotten now, but it's quite a large building. You really can't miss it unless you confuse it with the battery egg factory, but hopefully not. Will people please register for this so that we know how many people are coming? It's going to be 4 different talks about 4 different projects that Labman are doing, about 15 minutes on each topic with different people, so that should be quite interesting. Let's see if I can get rid of that. Right, now I've got another event to share, which is a visit to N&P Recycling. This is limited to 10 people, so it's a case of first come, first served. These posters will be on the website shortly, and that's got a flipping transition on it. Okay, let's try again. So these posters will be on the website shortly, so please contact me if you're at all interested in the visit to N&P or the visit to Labman. The visit to Labman is is at 3 o'clock in the afternoon. The visit to N&P is at 5:30. So please contact me if you wish to do either of those. Right. I've muted everybody again just to make sure we don't get any interruptions. Right, I think all that it remains for me to do is to introduce Shahrzad Shariatpanahi, who's a biomedical engineer and has worked on hip and knee joints. So I think without further ado, I'll hand over to you, Shahrzad. If you could unmute yourself, please. And the floor should be yours.
Thank you very much, Sue. Thanks. So good evening, everybody. First of all, I just wanted to say thanks to everyone for joining this session, and a special thanks to Sue and everybody at CIE for giving me this opportunity to speak with you tonight about joint replacement. So I'm so happy and excited to be here. I'll just start sharing my screen now. So please tell me if you can see my screen.
Yeah, that's come through.
Okay, thank you.
Although we can see, that's better. It's full screen now.
Okay, perfect. Thank you. Okay, so yeah, just a quick reminder, please feel free to post your questions if you have any questions on the WebEx chat, and I'll be more than happy to answer any questions at the end. Also, I have put my contact details at the bottom of all my slides. So again, feel free to drop me a message either on my email address or any one of the social medias you feel comfortable to contact me on. That's fine too. I'll be happy to help you if you have any questions. So yes, so this is an introduction to knee and hip joint replacement. And my name is Shahrzad Shariatpanahi. And just a little more information about myself. I did my master's at University of Leeds I did biomedical engineering. I then worked in the R&D department of an implant manufacturing company for a few years. I also wrote the book, We Tips on Knees and Hips. If you're interested, it is available to get online on Waterstone's website or Blackwell's. It is also available on Amazon as well. The social media accounts I have at the moment are listed here. Oh, sorry. What? Oh, I didn't mean to do that. Sorry. I'll share again, I guess. Can you see my screen still?
It's come back now.
Oh.
Yeah, I'm guessing you clicked stop sharing by mistake.
There was a message. I was trying to hide that message.
Right.
I hope it's fixed now.
Okay.
Thank you. So moving on. So yeah, before I start actually getting into the topic of hip and knee replacement, there's just a couple of points I wanted to mention. So first of all, I am not a medical professional or a doctor, so please don't take any information I share today as medical advice. And if you have any medical questions or concerns, it's best to discuss them with your GP. Other point I wanted to mention is that every individual's experience of a joint replacement is different and unique to that person. So as a joint replacement patient, please remember not to compare your progress or experience to other individuals. The reason behind this is because there are several factors that contribute to one's experience of a joint replacement. Some of them are listed here. For example, the orthopedic surgeon or the surgical approach used for joint replacement, the hospital policy, some patient factors such as medical history, activity level of the patient, their weight or body mass index, BMI, their anatomical features and joint condition, the patient's compliance, and patient's habits and behavior changes over time all contribute to their experience of a joint replacement. So knee and hip joint replacement, just a quick brief background. So what is a joint replacement? It is also called a total joint replacement or joint arthroplasty. It involves replacing a damaged, worn, or diseased knee or hip joint with an artificial one. And why do they do this? That is because the joint, hip or knee joint, is no longer functioning the way it is supposed to work for that person to be able to live independently and pain-free. Now, here to just have a quick look at some of the pioneers in joint replacement. Well, historically, there has been a lot of work done in this area since the late 19th century. And here are just two of the most notable joint replacement pioneers, Professor Glock from Germany and Professor Charnley from England. Professor Glock introduced the term arthroplasty in 1902. He designed and implanted the first artificial knee in 1890, and again manufactured and implanted the very first artificial hip in 1891. Professor Sir John Charnley designed the first low-friction hip system. That is the modern design we have today, on which we will be focusing today as well. Professor Charnley also worked on bone fracture management methods and also operating theatre improvements to reduce risk of infection. The pictures you can see on the right-hand side of the screen. Now, let's look at the hip joint. So, as you may have already heard this term, the hip joint is a ball and socket joint. The acetabulum being the socket located on the pelvis, and the femoral head is being the ball. So it is a simple ball and socket joint. There are a few soft tissue just holding the joint together. As you can see on the bottom left picture, the joint is not really exposed, it is encapsulated. And the picture on the bottom right-hand side is showing a ligament that is physically connecting the head of femur to the acetabulum, which is basically, this is the ligament that is completely removed in joint replacement, which means managing stability of total hip replacement is somewhat of an issue. So dislocation can happen. Now, this is just to basically point out the that the normal healthy hip looks different to damaged hip. In damaged hip, you can see that the cartilage is gone. If you look at the bottom pictures, the x-rays, on the right-hand side, you can visibly see a gap between the head of femur and the acetabulum. This is not visible on the left x-ray image. Now, hip joint function is weight bearing, load transmission, and leg mobility. The range of motion of the hip joint in different movements is listed in this picture at the bottom. So in the flexion movement and extension, the hip can actually move from 0 to 120 degrees. Abduction up to 40 degrees, and adduction, the movement can be up to 25 degrees. And also there's external and internal rotation, 45 degrees and 35 degrees respectively. The goals of a hip replacement are to relieve pain, restore function, and restore mobility, ideally back to the numbers that we can see on the screen here. Now, top reasons for hip joint replacement are listed on the screen. However, the one I want to be focusing on today is osteoarthritis. So that little pie chart on the left-hand side, that is copied from the National Joint Registry, which shows 88% of all primary replacements in the year 2020, which is the most recent published report, were due to osteoarthritis. Of all the patients, 60% were women with the age of just over 69 years old, and 40% of the patients were males with the age of over 66 and a half. The average body mass index of the patients would be considered as overweight. So at the bottom, I'm just referring to 3 different types of hip replacement. The first one on the left-hand side is hemiarthroplasty. That usually is used when the fractured neck of femur happens, so neck of femur fractures. And then there is hip resurfacing, and total hip replacement is really the last stage, the last treatment. So yeah, here we are looking at the femoral component. Please take a moment to look at the implants on the right hand side. So yeah, this is not even all of the implants that's on the market right now. Just to show you the difference in shapes of implants, and also yeah, so on the bottom left you can see stem geometry cross section. So if you look at the first circle on the left hand side, it's a cross section of the femur shaft, and then the circle and the rectangle are basically showing you the cross section of the stem. So it can be in many shapes. It can be a circular stem, it can be rectangular, it can also be triangular and trapezoid at times as well. And the last 4 circles are showing you the size of the stem in comparison with the size of the femur shaft, and also something I will talk about later, which is the use of bone cement in implantation. So going back to the list of, in the little blue boxes I have here, So we have monoblock or modular stem. So monoblock is when the head of the stem is connected as one component. So the head and the stem are connected. Modular is when the head would be inserted during the surgery. So number one, basically, on this picture is a modular system. Then there is colored and colorless stems. So sorry, just 1 second. I think I'm having internet issues. Apologies. Can you hear me fine? Sorry.
Yes, we can hear you fine, and we
Oh.
can see the slide with all the different implants.
Yeah, thank you for confirming that. I just had a sorry, I thought the connection was lost. Okay, so going back to the slides. So there are horizontal or vertical grooves on some of the stems. The stems are made of different alloys, such as cobalt chromium, or stainless steel, or titanium. The surface, the fixation surface of the stems can be smooth, or can have some sort of coating on them, which I will explain shortly. And they can be cemented or cementless. Again, I will talk about that as well. So firstly, the fixation surface. There are two types. They're either HA coated or hydroxyapatite coated, and porous coated. So hydroxyapatite is a white powder-like substance that is applied to the only fixation surface of the hip implant, as you can see in the pictures here. And porous coating is basically using one of these methods listed here, and they would make a rough surface on the femoral stem. So the methods are plasma sprayed surfaces, or sintered beaded surface with small or large spheres, and diffusion bonded fiber metal surfaces. This is all to make sure that bone growth is happening and the bone is actually bonding to the stem. The bonding time, however, is a bit long, so it can take approximately 1 year for secure bonding to form with this method. The other option is using cemented hip joint, which there is bone cement involved in this system. So bone cement, or polymethyl methacrylate, or PMMA, is basically used as a glue to put the stem and bone together, and it is mixed at the time of the surgery, so it's not something they can prepare in advance. And as you can see in the pictures, that is how it's put inside the shaft of femur, and then the stem is inserted onto that. The bonding time in this method is only 10 minutes. Now, a little case study here about biomechanical performance of the cemented hip stem with different surface finish. So we have the option of polished surface and sandblasted surface hip stem. So the outcome of this study was that the polished metal had superior bonding with bone cement under tensile loading. In contrast, the roughened metal generated higher interface strength when resisting shear loading. So for that reason, a combination of both is a suitable option that surgeons might pick. So let's look at the other components in a hip replacement. So there's the head, which can be anywhere from 22 to 54 millimeters in diameter. The material of the head of the hip implant is either metal or ceramic. It can be, again, monoblock or modular, as I explained previously. It can be bipolar or unipolar. Not sure how visible the picture on the right-hand side is, but basically a bipolar head, there's a head inside the head, so two bearing surfaces, but unipolar is just one head on the stem. Now, if you look at the liner here, so liners can be made from ceramic or polyethylene. Here we are only looking at the polyethylene or PE liners. The type of PE used in manufacturing hip implants is called ultra-high molecular weight polyethylene. Cross-linked polyethylene is also used. Now, just to give you a better overview of the superior performance of cross-linked polyethylene compared with a regular polyethylene, which is like plastic, we can look at the picture on the left-hand side here, showing the wear rate of these two types of polyethylenes. The wear rate of cross-linked polyethylene is way less than a regular linear polyethylene. And to show you the mechanical strength of cross-linked polyethylene, here I have a couple of videos, very short 10-second videos to show you. So on the first video in the middle, if I can play that, yes. So here there is a 3,000-gallon polyethylene tank. The one on the left-hand side is a linear PE. The one on the right-hand side is what we are interested in, cross-linked polyethylene, with 7,000 pounds of water inside, being dropped from 15 feet to a concrete surface. And you can see the catastrophic failure on the linear polyethylene tank. And also on the right-hand side, I have another video I'll play now. A PE or polyethylene tank. Again, the linear polyethylene is on the left-hand side, and the cross-linked, what we are interested in, is on the right. It is being pressurized to failure. Now, if you have a look, yeah, so it is not exactly visible here, but on the right-hand side, there is a 6 to 8 inch crack being developed at the top of that tank, which lets water out. So it certainly did not fail catastrophically. And then at the bottom, we have the shell or acetabular cup of the hip system. So it is made of either cobalt chromium, stainless steel, or titanium. And there are two surfaces, the fixation surface and the bearing surface. The fixation surface is the back of the implant being attached to the bone, to the acetabulum. And the bearing surface is where the liner would be inserted in. There are additional fixations. The two pictures you see here basically show additional fixation like bone screws or plugs for better attachment to acetabulum. Now, bearing options for a hip system. As you can see, there is a number of options that surgeons might pick based on their experience. I'll just give you a little bit more information about each system. These are in order of their basically wear per year rate. At the bottom, you can see that number, however, it's too small. So the MOP system, I'll explain, has the highest wear per year rate, and the COC system has the lowest. So MOP is metal on polyethylene system. That is referring to the metal head and the poly liner. So that's a very good system. It's in use. It's one of the commonly used options, basically. The COP is ceramic on polyethylene. Again, it's referring to the ceramic head and the poly liner. Again, that's one of the popular options as well. The MOM is referring to metal on metal, metal head, and metal liner. This is not a great option. I don't think anyone is using this any longer because of the debris generated. The metal debris reacts with soft tissue and causes severe injuries. And the one on the right-hand side, COC, ceramic on ceramic, so both head and the liner are ceramic. Again, despite the very good wear rate, very low rate, it is not a very popular option. The reason being, it makes a squeaking sound when the patient walks, so it's not very pleasant. The metal on metal movement, sorry, the ceramic on ceramic movement makes a noise. Okay, here we have hip replacement failures according to National Joint Registry. So we have loosening. Now, if you look at the picture at the bottom on the left-hand side, if you look at the arrows, you should be able to see that it appears that the implant is being detached from the bone, not entirely, but that is what we call loosening, which is the top reason for failure of primary hip replacements. That is 0.11% of all primary procedures. The next one is dislocation. Again, the second picture from the left at the bottom. That's when the head of the implant is dislocated from the acetabular shell. Then we have infection. It's not really visible on the X-ray. You can see symptoms or signs of it. The next failure is bone fracture, which is very visible on the fourth picture down at the bottom. And then we have adverse tissue reaction. What we can see in this picture, the last one from the left, is basically the worn liner is visible. So the head is off center because the liner is worn on this side. And usually a worn liner would mean some sort of reaction with the soft tissue because of the particles and debris. So here are some more pictures. So this one shows loosening of the acetabular cup. This is dislocation at the top and polyethylene liner wear at the bottom. Now, precautions after hip replacement to avoid a revision surgery. So to reduce risk of dislocation, which is one of the failure modes that is quite common, is to avoid bending your hip joint over 90 degrees. Now, the position shown in the image is not usually how it happens. Usually it happens when you're trying to sit on a chair or a stool that is too low, too short for you. And you should avoid rotating your leg from the hip joint internally or externally. It is recommended to use raised toilet seats and a stool when taking a bath. Now we can look at the knee joint. Now here just a couple of pictures of the knee joint, just to give you an idea of how many bones are involved and what's soft tissue around the knee joint like. So there is the proximal end of tibia, distal femur, there's patella and fibula as well. The soft tissues included are the menisci on tibia and also the anterior cruciate ligament and the posterior cruciate ligament in the middle of the knee joint on this picture. And also, if you look at the muscles around the knee joint and all the soft tissue, it is very different than what we had in the hip joint. So basically, this joint, knee joint, is very exposed compared to hip joint, which is what which makes the management of this joint a little challenging when performing knee replacement. And the last picture on the bottom right is just to give you an idea of how patella would need to be compatible with the surface of femur to make sure that the movement is natural when trying to create, trying to basically design an implant for patella. Now here is a list of knee function and basically all the functions, but what I want to emphasize on right now is the movement of the knee joint. So if you take a good look at that video, you can see that the knee joint does not have a regular just roll motion. So if you imagine this is my femur and this is tibia, so the motion is not just a single roll, it rolls and then glides back, okay? So there's also a motion of spin as it's shown on the picture, but that is really, really minor. So it rolls and glides. And the degrees of freedom of the knee joint is 0 to 140 degrees. Okay, so top reasons for knee joint replacement, again, are listed on the screen. However, I would like to emphasize that osteoarthritis is the top reason for knee replacement. 97% of everyone that had a knee replacement did have osteoarthritis, of which 55% were females with the age of 69 years old, and 45% were males with the age of over 68 and a half. And the average BMI or body mass index for all these patients indicated obese. And if you look at the pictures at the bottom, you can see that joint replacement option for osteoarthritis at an early stage is partial or unicompartmental knee replacement. So that's what you can see at the bottom, rather than having the full total knee replacement. This is to fix only the damaged part of the knee joint. However, today our focus is on total knee replacement, so I won't be covering this type of knee replacement tonight. So knee implants, there are several parts. So there's a femoral component on the top, at the bottom of the femur, and then there's PE or polyethylene insert, which is invisible on X-rays, and then there's the tibial component, which is inserted inside tibia. Knee implant fixation surfaces are exactly like hip implant fixation, so they can be cemented or uncemented with some sort of coating on the fixation surface of the implant. The picture on the top left shows porous coating, as I explained earlier with hip implants. So yeah, there are different designs for different components of a hip replacement. So here we are looking at femoral components, and these are just two examples of femoral components. The one on the left-hand side is cruciate retaining femoral component, which is referring to the PCL or posterior cruciate ligament that is being kept. So that is to help with the stability of the joint. And the one on the right-hand side is called posterior stabilized femoral component. Again, in this system, the femoral component together with the poly insert, the combination provides a locking mechanism and provides stability for the femur, for the knee joint, basically. And if we move on to tibial components, as you can see, tibial components can be either modular or all PE or polyethylene. So all PE components are not very popular. However, the modular system is popular and there are different options as well. So the one you can see on the left-hand side is called a rotating platform tibial component. So what that means is the insert, the poly insert, can rotate over the tibial component, as you can see in the image. So the other system is fixed bearing. That's the second picture from the left. That's the fixed bearing system. There are different locking mechanisms for the insert and the tibial component to be attached and secure in place. One of the locking mechanisms you can see on the second picture from the left. Another locking mechanism is Logilock, sorry, on the third picture. And again, these are just a few of the options. Patellar components. Again, there are different designs, different shapes and sizes for patellar components. Some of them are shown here. The only thing I want to mention is that the patellar component can be all poly or it can have a polyethylene surface and a metal back. Again, like I said before, the important thing is that the patella and the femoral component are compatible, as you can see in the picture, to make sure that the movement is done smoothly, and basically the patient is comfortable with the movement. Now, knee replacement failures. These are the top reasons for failure, and the rates are based on the revised knee replacements, meaning that of all of the failed implants, 38% were due to aseptic loosening, for example, and not all of the primary surgeries. So aseptic loosening is when loosening is not as a result of infection, and that's the highest score. The picture on the left-hand side is showing loosening of a femoral component. Then there's instability, which is an issue, considering there are not much soft tissue around the knee joint to hold the joint in place. And then there's pain and wear of components. In this picture down bottom at the right, you can see the wear on polyethylene insert. A few other pictures of failure of the knee joint. On the left-hand side, polyethylene wear. In the middle, we have dislocation, and on the right, loosening of the tibial component at the bottom. And this is pre-prosthetic fracture, which means that the bone near the implant is fractured. After knee replacement surgery, and to protect your new knee joint and reduce risk of revision, it's recommended to avoid high-impact activities. Running and jumping are not encouraged. Now, when I say that to people, sometimes I hear back, but I can do it. I did running and things like that. It's not that you cannot do it. It will increase the risk of failure. Also, it's recommended to avoid crossing your legs or rotating operated leg or any heavy manual labor. And these are the same for those who underwent a hip replacement as well. Now here's just a little case study on a right total knee arthroplasty of a 51-year-old male. So the patient experienced work-related injury in the past, been in pain for 8 years, not been able to return to work or complete activities of daily living without pain. The range of motion, flexion and extension were 10 compared to the 120 I mentioned earlier, 10 degrees. Pain worsened over the past 1 year, tried physio and pain meds, but didn't help. Pain scale of 8 out of 10. Now, if you just have in mind that 10 out of 10 is when you pass out from pain, so 8 is a really high number. The patient underwent a sequence of cortisone injections, which provided relief for just about 3 weeks. No additional medical conditions or complications. Overall healthy, making him a great candidate for total knee arthroplasty. So the patient underwent a right total knee arthroplasty successfully. There was satisfactory alignment of the prosthesis. There was soft tissue swelling, which is consistent with recent surgery, but no loosening, which is great. Physical therapy for range of motion and strengthening for 6 weeks. And then the patient returned for a 3-month follow-up with full weight bearing, substantial range of motion, and 0 out of 10 pain scale. Patient continued to follow up as needed. So this is basically a success story of a total knee replacement. Now, if you look at knee and hip joint replacement surgical operation. So before the surgery, the medical team would need to prepare by looking at the patient's medical imaging, like X-rays, and plan the surgery, and decide what components, which hip system or knee system they are likely to be using for this patient. And the patient would need to do a few things as well. So the patient would need to be decluttering their home, basically to make space so that they are able to walk with a walking frame the first few weeks after the surgery inside their home, and also to reduce risk of falling. The patient would need to know that they cannot drive immediately after the surgery, so they need to arrange delivery and pickup if they have any children, if they have any responsibilities that need to be managed in advance of the surgery. They would need to either order assistive devices like the walking frame, or they would need to talk to their clinic or hospital and check if these will be provided to them. And the patient would need to prepare a hospital bag. And again, they would need to check if they're staying overnight or not, just so they can prepare for it. So the surgical team, just wanted to clarify, there are about 6 or 7 people in the operating theater with the patient, including the orthopedic surgeon and the medical device company representative. And the surgical approach is completely up to the surgeon. As a patient, you can discuss this with the surgeon prior to your operation, but so there are different approaches. These are again just some of the examples for both hip and knee joint. Now, after joint replacement surgery, to reduce pain and swelling, you would need to be using medication. You would need to use ice pack on the operated joint, so apply ice pack on it. And you would need to keep active little and often. To regain range of motion, you would need to do both home exercise and physical therapy. Sometimes the patients think it's one or the other. You need to do both. And follow-up visits as well. So some precautions after joint replacement in general. So to protect your new joint, you should use some equipments. I mentioned a few before. A reacher grabber, a raised toilet seat are very useful. Avoid certain movements depending on whether you're going through with hip replacement or knee replacement. You will be provided with a list of do's and don'ts. And you should follow these rules for a certain period of time. It's usually between a few weeks to a few months. Post-operation patient satisfaction. So satisfaction after the operation is usually somewhere between good, very good, excellent, with minor cases of fair and poor. And problems now compared to before the operation is generally much better. Now, as you can imagine, the amount of hip and knee related information out there on the internet can be overwhelming. So here are my suggestions for reliable sources of information for hip and knee replacement. So firstly, it's your surgeon, GP, or medical team that you can speak with. And the second resource would be reports from joint registries. Here I have 3 examples. The one on the left is the National Joint Registry, which covers information from hospitals across England, Wales, Northern Ireland, and Isle of Man. The one in the middle is the US Joint Registry. The one on the right-hand side is Australian Joint Registry. So finding local data on National Joint Registry. So it's very easy to find local data about joint replacement. If you go on surgeonprofile.njrcentre.org.uk, you should be able to click on your region where you live. And then the website will provide you with a list of NHS and private hospitals. And if you click on the hospital, name, you should be able to find some very useful information about all the hip and knee primary and revision procedures performed at that hospital. Yeah, this is just a quick reminder that the decision-making process is really a team effort. So it's never only the surgeon's choice, and it's never only your choice. It's you have to discuss things together. The decision at the end of the day is based on the surgeon's recommendation and expertise, the research and that evidence that is available to review, and also your concerns and your choice as well. Now I just have a couple of slides on what's new in the world of joint replacement. So the first one is coating to reduce early post-surgical infections. So this is antibiotic-releasing nanofibers or antibiotic-loaded hydrogel, which is applied to the fixation surface of the implant prior to implantation. The next one is vitamin E diffused polyethylene liner. This was developed to reduce wear and loosening of implants. However, as you can see on the chart at the bottom right-hand side of the picture, the results were not much better than what's already out on the market, which is the cross-linked polyethylene. And lastly, robotic arm-assisted joint replacement. So there are a few options for robotic assisted joint replacement. So there's Mako by Stryker, there's Robodoc, Navio, and Cori by Smith and Nephew, and Bellis by DefuSynthese. So these robots basically take all the patient's information in advance of the operation and then give the surgeon a better understanding of what components to pick for the patient. They also help the surgeon perform the surgery, so make a more accurate incision, more accurate trimming of the bone. So it is known to be way more accurate than just conventional methods of joint replacement. Thank you very much for listening, and I hope that you found this useful and interesting. And I am more than happy to take any questions you may have.
There are a couple of questions from Marcus Hamler in the chat box.
Okay, sure. Shall I stop sharing? I'll stop sharing then. Okay.
Yeah. Do you want to read it out? Can you read it, or shall I?
I can read it. Yes. Yeah. Okay. So I think the first one is at the top. Thanks for the fantastic insight into all the options available. I'm amazed there are so many options. How does an orthopedic surgeon decide which is best for a particular patient? When selecting engineering bearings, there are well-established decision rules. Is this true of human joint bearing, or do doctors each have their own preferences? Okay. Yeah. Yes, certainly. So the surgeons would have their preferences as well. So what my understanding is that the surgeons would be working with certain joint replacement providers, like manufacturing companies. So they actually consult with them about what is working with what implant and what is not. So based on the continuous development of that manufacturer, they keep working with that manufacturer. But again, there are studies that are shared, peer-reviewed and shared. So that is another source for the surgeons to review. Yeah, so it depends on the experience of the surgeon, really. I'm not sure, did I answer that fine? Do you have any follow-up questions? Or Shall
Well,
we?
there is a second question.
Okay, that's fine. I'll just continue on the list.
Okay, fine.
How much does the surgeon's skill come into the success of the operation? Is it an art or a science? Good engineering bearing, badly fitted will still fail. Definitely, yes, yes. So yeah, it does definitely play an important part, the surgeon's skill, and it appears to be an art as well. Yes. So this is why the National Joint Registry website is a good resource to check that. You can see how many operations a year different surgeons do on hips and knees, primary or revision. So I would definitely recommend checking that out. How long before robots take over? That's a very good question. I don't know, that's already started, I guess. But yeah, robotic assisted joint replacement is a very interesting, quite new area. So yeah, what sort of quality control is used in the manufacturing of these medical devices? So yeah, so there are many basically regulatory bodies that the manufacturers would need to comply with. So I do have a list of, so there are some standards that the manufacturers would need to have in mind in the field of medical devices. So there's ISO 13485, that is for quality management system requirements for medical devices, implantable medical devices. So yeah, there are many regulatory bodies when it comes to implantable medical devices. Are the wear rates and mechanisms dominated by mechanical wear or biological interaction with the joint materials? Yeah, I think at the end of the day, it's all about the patient's safety. So I would think that it is about biological interaction. So if the debris generated is inert to human tissue, that is less of a concern compared to when it is actually reacting inside the body, like metal on metal system. That's why they're not used any longer. Any idea on cost saving possible if obesity and overweight could be reduced? Also, anything else people could do to reduce likelihood of needing? Yeah, certainly there are things that people could do to reduce likelihood. Just keeping active, strengthening the muscles around the joints would definitely help. Postponing that need to do joint replacement. About the cost saving of, I'm not entirely sure how to respond to that. I'll just move on to the next ones I may get back to that later. What other joints can be replaced? A friend of mine recently had a thumb joint. Yeah, almost any joint can be replaced. So yeah, there are a joint replacement. The next popular one is shoulder replacement, and elbow replacement, ankle replacement. These are the very common ones. But yeah, that is correct as well. How are the components made? Are they forged, cast, or powder formed? Yeah, so the it depends on the material. So metal parts, I do believe some parts are cast, made through casting. I don't have a vast knowledge on that side of things, but I know they are currently working on making the process more cost effective, as well as to produce less waste. They are looking at 3D printing of implants even. So yeah. Are there fake medical devices being sold in the marketplace, or have scammers not? No, no. It can't be, because the regulations are really tight around that area, and the hospitals and clinics are very, very careful with that. Are there any reason? Yeah, there might be. Yes, I would say yes, definitely. Yeah, differences in the strength of bone and metallic implant are significant. Could this encourage bone fracture? Yes, it does. Yeah. So what happens is stress shielding. In some cases, it depends on the alignment of the prosthesis inside the bone. So if stress shielding does occur, it is very likely for the bone to break, which requires a revision surgery. Yeah. Okay, I think I covered everything for now.
Right, well, certainly a healthy selection of questions. Yes, I'm not sure it's all obesity-led. My aunt had a hip replacement and she didn't weigh more than about 7 stone wet through. She was exceedingly thin, so I presume that was more due to osteoarthritis setting in. Maybe it was hereditary because her mother was fairly similar as well. So I'm just hoping I don't go down that particular avenue.
Sue, if you don't mind, I've got a question that.
Oh, sure, carry on, Vince.
I've been now waiting for 12 years for my right knee to be replaced, and it seems to disappear in the future. What decisions are taken when you discuss it with the consultant about materials? 2 people I know have had replacement hips, have found themselves being allergic to chromium. Mm-hmm. So how do they assess that risk?
Yeah, that's a very good question. So if the patient is aware of any allergies in advance, they can certainly use an implant that doesn't have that specific component, that specific metal inside. So there are, off the top of my head, I think there are some implants including nickel instead of some of the metals used. But anyway, so if you want to test that, I'm sure the surgeon would be able to advise on how to test if you have allergy to any of the metals used in that implant. If it turns out that you do have an allergy, there is certainly a way around it, but you would need to check that medically first. There are also custom-made implants as well, which is very popular nowadays. Again, that is another option, that they make an implant for you, for only for you, basically. So yeah.
Thank you.
No problem.
Hello, you got me, Eric?
Yes. Oh, hello, Merrick. Yes.
My question doesn't seem to have got on the list, but does titanium have a better natural bonding process with the bone than other metals?
Sorry, what metal? I didn't catch the first part.
Titanium.
Oh, titanium. Okay. So the bonding. So the bonding of bone to the metal is dependent on the surface of the metal. So if you're talking about porous surface, so it's either cemented or uncemented. Now we're talking about titanium, so it's about the porous coating on that metal. So it's not only the material, but also the method used for the creation of porous coating. So I cannot tell you which metal or which porous coating has better outcome or better bonding. There is researchers online, but off the top of my head, I don't think I've come across a research that tells me this metal it creates better bonding. I'm not sure about that.
Thank you.
I've just noticed a comment from Tony saying that his experience was there was no discussion about implant materials as such, but he was asked if he was allergic to nickel.
Okay. Yes, sometimes it's best. I do have a list of questions I offer to people who want to go have that discussion with their surgeon. So yeah, it's knowing what to ask in that early stages, how to take basically information from your doctor. That's a bit tricky. You should know in advance what you want to get out of your conversation. But yeah, I agree. Sometimes they just go right into it and just book the surgery. Yeah.
There's another comment here. Somebody, John, no surname, says the range of fundamental surgical approaches is quite wide and seems to depend a lot on the surgeon's personal preference. This seems unusual in medicine. Is it likely that these will converge in the future to a preferred approach?
Yes, but the other thing to have in mind is if, for example, you look at that surgeon's profile on National Joint Registry website, if you see how they've performed in the past, how many of their implantations have been a success and failure, that gives you a good understanding of what they're doing is okay or not. I understand, yes, it's up to the surgeon to decide which approach they're going to use, but if down the line turns out that approach is not working, there should be an indicator for that, for them to update their methods, I guess.
Stuart Millman is asking about current waiting times. He says, how long are the current waiting times for these post-COVID? I don't guess you're not likely to know that, are you?
Well, not currently, no. I knew that due to COVID, the surgeries were cancelled and postponed for a few months, even up to a year. I know that much. Right now, I think they're putting everyone back on the list, on the waiting list, to actually book in and go for their surgery. But I don't have an exact time frame now.
Well, a further question, if I may. Sue?
Yes, Merrick.
In the early days, they used PTFE sockets. I'm not a plastic expert. How does that compare with the plastics currently used?
What is PTFE? I'm not sure I know that.
Or ethylene.
Okay.
In the early days, that was found as a plastic good for friction.
Okay, so you mean, is it for the hip system, the liner?
Yeah, it's sometimes known as fluon. Fluon? No.
Yeah, I'm not sure. What I can tell you is that if you mean the hip system and the liner, it's certainly either ceramic or cross-linked polyethylene. Previously, it was ultra high molecular weight polyethylene. I'm not sure if there is another option for these. I haven't come across. And for me, it's certainly just polyethylene, cross-linked, highly cross-linked.
Thank you.
There's another question here. What's the record for a replacement time? I'm presuming that means what's the fastest. And I'm not sure whether the person means the actual time taken to do the operation or the waiting time.
Yeah, so the operation time can be anything between 2 to 3 hours. I've heard of the incidences where the time was took longer to because of the complications during the surgery. But yeah, if fastest, yeah, I don't have a figure for fastest. On average, is 2 to 3 hours.
Okay, I think I could answer part of that. An old squash colleague of mine, he was still playing at 65, whereas I had to give up at 50. He had rickets as a child, which put an awful lot of strain on both knees. He had his left knee replaced once and his right knee replaced 3 times. And his right knee, of course, was much shorter, at which point he had to sort of give up playing squash, but he was still playing at 65. So he didn't get it done on the NHS, by the way. He had to pay for it, the second and third one. But it can be done. But you have to change your lifestyle.
Definitely. Yes, totally. Yeah.
Yeah, I wouldn't have thought squash was a very good idea with any sort of joint replacement.
In the early days, talking about life, they wouldn't do the hip operations on younger people because it wasn't going to last. Can they last, in fact, 20, 30 years, or are they bound to be replaced before then?
Basically, the R&D departments of the manufacturing companies are working on that, making the implants last longer. At the moment, the average is 15 to 20 years, but we are moving that way. We are hoping to be creating implants that last for a long, long time. At the moment, it's only up to, like, on average, 15 to 20 years. There has been incidences where it lasted in patient's body for a long time, but it's not very common.
Thank you.
I think that answers Stuart's question as well.
Sue, I could ask a question.
Yeah, Terry.
Yeah, you may remember. I'm trying to remember how long ago. Maybe 20 years ago, we had a surgeon, an orthopedic surgeon, do a lecture on principally on hip replacements.
Yes, we did. I remember that.
And he brought some examples along. And the lowest friction components was the ceramic ones by far. But he did say at the time that they were prone to brittle fracture. Has there been any materials development since then that makes it less prone to brittle fracture, but still retains the friction properties?
Yeah, so yeah, I haven't come across any cases where the liner or the head of ceramic material were fractured. So that's not something that happens very often nowadays. So it's not the fracture that's the problem, is what I'm trying to say. The squeaking, the noise that the implant makes is making the ceramic on ceramic system less popular. But yeah, like you said, it's a great system for low friction bearing surface. So yeah, it's definitely a good system. It's just making the noises a bit not great.
There's another question from Stuart here saying, can you do second and third time surgeries? I'm guessing after Vince's comment, yes, you can.
Yes, you definitely can. Every time you go through with a revision surgery, which is after the first implantation, it's a revision second and third time. The implants get larger because you lose bone every time you go through with the surgery. So yes, you can have several joint replacement on the same hip or knee joint, but it's just that the implants get a tiny bit bigger to fit the area better.
Yeah, Stuart, do you remember Peter Sterrett? He had at least 2 hip replacements, and his problem was that the bones started to crumble, and they ended up just having to take it all out, and basically his leg was useless. Do you remember him, Stuart?
Yeah, I do. Yeah, exactly what happened. Yeah.
I guess he had some problems other than just whatever it was that caused him to need a replacement in the first place. He was not a well person, shall we say.
But you would expect it to weaken anyway, wouldn't you? Every time you have surgery in the same place, you'd expect that everything to weaken.
Yeah, you would. Yeah, Peter's no longer with us, alas. Paul Frank's asking, do you know if any have been done on other animals, e.g. dogs? Well, do you not watch the Super Vet, Paul? He does all sorts of joint replacements and bone surgery on various animals. It's usually on Channel 4, but I haven't seen it recently.
Yeah, exactly.
Do you know anything about animal?
No, my knowledge is from the exact same show. So yeah, I know it is done, but I don't have much information on animals joint replacement. There was another question. Yeah, sorry.
You need to pay for it, of course.
Mm-hmm.
Yeah, somebody's asking, how do they remove the implant in the femur?
Yeah,
very carefully, I would have thought.
They have different instruments for insertion and also removing implants. So they would be using those instruments. It's not a very difficult task with the instruments they have.
Oh, Paul says no, he doesn't watch much TV. Right, well, I think that seems to, the questions seem to have dried up now, unless anybody else wants to ask anything further. No? Well, I think in that case, I'll say thank you very much, Shahrzad. That's been really interesting. I think we'll all be losing weight immediately to try and make sure that we don't need any of these implants. Having experienced various relatives having hip implants, you're right that the outcome can be very varied. I know with my mother-in-law, the one that she had that was planned was very good, and she made a very good recovery, but then she had the other side done as a result of a fall and a fracture to the neck of the femur, and that was nowhere near as good. Now, whether it was just in the skill of the surgeon, because obviously the one where she broke the hip, she just had whoever happened to be on duty that day, whereas the planned one was done with a specific guy, you know, who had a good reputation. So I don't know. I think it also depends how much notice you take of what one of my friends described as his physio-terrorist, whether you do your exercises properly or not. So, right, anyway, I think we'll say thank you very much to Shahrzad. That was really interesting. If anybody wants to sign up for either the visit to NNP or the visit and the talks to Labman, please get in touch with me. So I think on that basis, we'll say cheerio. Thank you very much.